Hello everyone and welcome to our module on the pupil. The pupil is the black circle you see when you look at your eye in the mirror. It's in the center of the colored iris, and it allows light to enter the eye and then pass through the lens of the eye and then go to the back of the eye and hit the retina, where light signals are picked up and transmitted to the brain. The size of the pupil is not fixed. The body can adjust the size of the pupil to control the amount of light entering the eye. And when the pupil contracts or shrinks in size, we call that miosis. And when the pupil dilates or increases in size, we call that mydriasis. And these changes in the size of the pupil are under autonomic control. You cannot voluntarily make your pupil increase or decrease in size. The iris is the colored portion of your eye that surrounds the pupil. It's a contractile structure made up of mainly smooth muscle, and it controls the size of the pupil. Within the iris, there are two important muscle groups that control the size of the pupil. There's a circular muscle group called the sphincter pupillae and a radial muscle group called the dilator pupillae. Shown on the screen are the orientations of the sphincter and dilator muscles of the iris. So the sphincter pupillae is a circular muscle, as I said before, and when it contracts, it decreases the size of the pupil. The dilator pupillae is a radially oriented muscle, so fibers are sticking out from the center of the eye, and when the dilator pupillae contracts, it increases the size of the pupil. Now let's talk about the neural pathways involved in the process of miosis, which is pupillary contraction or shrinking the size of the pupil. Miosis is under control of the parasympathetic nervous system, and it involves a two-neuron pathway that begins at a structure known as the Edinger-Westphal nucleus, which is found in the midbrain near the cranial nerve 3 or oculomotor nucleus. Nerve fibers from the Edinger-Westphal nucleus travel and enter the orbit together with nerve fibers from cranial nerve 3. They synapse at the ciliary ganglion, which is found behind the eye, and then ciliary ganglion cells signal the sphincter pupillae muscle via the short ciliary nerves. They use acetylcholine as a neurotransmitter acting on muscarinic receptors. And here's a picture just to make this more clear. It begins in the Edinger-Westphal nucleus. Nerve fibers travel together with cranial nerve 3 fibers to the ciliary ganglion. From there, nerves activate the sphincter pupillae, and that's what leads to miosis. The most important clinical application of this pathway is called the rule of the pupil. This is important when evaluating cranial nerve 3 lesions. Patients who develop a lesion of cranial nerve 3 will have their eye down and out on the affected side. If you look at this picture at the bottom of the screen, this man's eye is down and out, and that is what you see in a cranial nerve 3 lesion. When faced with a patient like this, it's very important to evaluate the pupil and decide whether there is pupillary dilation or not. If the pupil is dilated, this means the parasympathetic nerves are impacted. The parasympathetic fibers run on the outside of cranial nerve 3. This makes them easily compressed by a mass, especially a posterior communicating artery aneurysm. So if the pupil is dilated, you must consider that the patient may have a mass lesion like an aneurysm, and those patients often need imaging of the brain. If there is an absence of pupillary dilation in the setting of a cranial nerve 3 lesion, this suggests ischemia is the cause. Cranial nerve 3 is vulnerable to ischemic nerve damage, especially in patients with diabetes. This type of damage to cranial nerve 3 usually spares the superficial parasympathetic fibers, and thus the pupil is not dilated, and this is called the rule of the pupil. Another rare condition that involves the parasympathetic pathway is called Addy's tonic pupil. This is a dilated pupil on one side caused by blocked parasympathetic innervation to that eye. Most cases are idiopathic, but it can be caused by orbit disorders that damage the ciliary ganglion. So for example, a tumor or inflammation or trauma or surgery or an infection could damage the ciliary ganglion. As a result, the pupil on that side will not have parasympathetic innervation, and thus it will be dilated because the parasympathetic system is unable to constrict the pupil. Now let's talk about the neural pathways involved in mydriasis, which is the process of dilating the pupil and increasing its size. This process is under control of the sympathetic nervous system. Dilation of the pupil is part of the fight or flight response. The sympathetic nervous system can activate the dilator pupillae muscle to increase the size of the pupil. It can also inhibit the sphincter pupillae muscle. This uses norepinephrine as a neurotransmitter acting on alpha-1 receptors. In contrast to the parasympathetic system we just talked about, the system for mydriasis is a much longer system. It involves a 3-neuron chain. It starts in the brain and travels down to the spinal cord and then back up to the eye. The first neuron travels from the posterior hypothalamus through the brainstem to the spinal cord and ends at a structure called the ciliospinal center of Budge, which is found at the C8 to T2 level in the spinal cord. The second neuron travels from the spinal cord to the superior cervical ganglion. It exits at the T1 level and crosses the apical pleura of the lung, and then it travels with the cervical sympathetic chain near the subclavian artery. The third neuron travels from the superior cervical ganglion to the dilator pupillae muscle. It courses with the internal carotid artery and passes through the cavernous sinus. This slide shows my own summary. It begins in the midbrain. The first neuron travels all the way to the spinal cord at the center of Budge. It exits at T1 and goes up to the superior cervical ganglion, and from there nerve fibers go to the dilator pupillae muscle. Because the sympathetic neural pathway is so long and convoluted, it can become easily disrupted in a number of pathologic states. And anytime there is disruption of the sympathetic chain to the face, this can result in a characteristic syndrome known as Horner syndrome. Patients who develop Horner syndrome will have a small pupil, which is miosis. This is because they've lost sympathetic innervation to the face, and thus the pupil is contracted. Basically, they have unopposed parasympathetic contraction of the pupil. Patients with the Horner syndrome also have eyelid droop, which is known as ptosis. This is because the sympathetic nervous system supplies the superior tarsal muscle, which assists the levator palpebrae in raising the eyelid. And then finally, the third characteristic of the Horner syndrome is absence of sweat on one side of the face. This is called anhidrosis. So many people remember that the Horner syndrome consists of miosis, ptosis, and anhidrosis. And this final symptom, anhidrosis, is usually not obvious clinically. These other two are what are obvious clinically. Patients have a small pupil and a drooping eyelid. There are many causes of a Horner syndrome. That's because the sympathetic chain courses near many important anatomical structures which can become diseased and interrupt the nerve pathway. Some that are worth knowing include an apical lung tumor, an aortic dissection, a carotid dissection, and a pica stroke, which can lead to the lateral medullary syndrome, which I discuss in the brainstem modules. Cocaine can be used as a diagnostic test for the Horner syndrome. That's because cocaine blocks the reuptake of norepinephrine. However, it has no effect if there is impaired sympathetic innervation to the pupil. So to perform this test, you apply a little bit of cocaine to the eye. If the eye is normal, it will dilate. If there is a Horner syndrome occurring in that eye and the sympathetic innervation is impaired, there will be no dilation. Normally, the cocaine is applied to both eyes. The normal eye will dilate massively, and the eye with the Horner syndrome will not dilate at all. The Horner syndrome is one of many causes of anisocoria, which is a difference in size of the pupils. If you look at this picture on the screen, this man has a large pupil on one side and a small pupil on the other. That is anisocoria. This can be seen in Horner syndrome. It can also be seen in cranial nerve 3 palsy with pupillary involvement. You can also see it in Addy's pupil. Depending on the cause, either the large or small pupil may be the abnormal one. So in Horner syndrome, the small pupil is the one that is abnormal. In a patient who has a cranial nerve 3 palsy or Addy's pupil, it is the large pupil that is the abnormal one. There are two pupillary reflexes that are tested as part of the physical exam to make sure the innervation of the pupils is normal. Those are shining light in the eye and asking the patient to focus on a near object, which is called accommodation. So we'll talk about these two reflexes now. To test the pupillary light reflex, you shine light in one eye and both eyes should constrict. The illuminated eye has what's known as a direct response and the opposite eye has what's known as a consensual response. The light signals are transmitted to a part of the midbrain called the pretectal nucleus. This nucleus can send signals bilaterally to the Edinger-Westphal nuclei, which we talked about before. This does not involve the cortex, it's purely a reflex of nerves, and once the EW nuclei are activated on both sides of the brain, both eyes will constrict. Here's an illustration depicting how this process works. If you shine light in the retina of one eye, the light signals will be carried by the optic nerve, cranial nerve 2, to the pretectal nuclei. Those pretectal nuclei can activate the Edinger-Westphal nuclei on both sides of the body. And then as we discussed previously, the Edinger-Westphal nuclei are part of the parasympathetic nerve system. They send signals via cranial nerve 3 to the ciliary ganglion, and from there the sphincter pupillae on both sides of the body will be activated. There's an important abnormality of the light reflex that you should know called the presence of a Marcus-Gunn pupil. This is an example of a relative afferent pupillary defect. I'll explain what this means in a minute. In a Marcus-Gunn pupil, light that is shown into one eye produces less constriction compared with light shown in the opposite eye. This is diagnosed by performing the swinging flashlight test. To perform the flashlight test, you shine light in one eye and you should see bilateral constriction of the pupils. You then swing the light to the other eye and the degree of constriction of both pupils should remain the same. If the constriction is less when you shine light into one eye, in other words, if the pupils dilate to some degree, this means there is a problem picking up light in one of the eyes, and this is known as an afferent pupillary defect. The Marcus-Gunn pupil is an example of an afferent pupillary defect. It's called afferent because it's caused by a lesion in the afferent limb of the light reflex. There is a problem sensing light appropriately. There are many potential causes of the Marcus Gunn pupil, including problems with the retina and the optic nerve, but a classic cause that you should know, especially for step 1 of your boards, is optic neuritis. This is an inflammatory demyelinating disorder of the optic nerve, and it commonly occurs in patients with multiple sclerosis, and it will present with a patient who is having vision problems and has a Marcus Gunn pupil after performance of the swinging flashlight test. The second pupillary reflex that you can test on physical exam is the accommodation reflex. Accommodation is the process of changing the optical power of the eye to focus on near objects. It involves very important changes in the lens, which I discuss in another module, where the ciliary muscles of the eye change the shape of the lens. However, associated with this changing of the shape of the lens, there is miosis, which is pupillary constriction. This means that when patients focus on a near object, not only does the shape of their lens change, but the pupils will also shrink. When you focus on a near object, there are 3 reflex actions that occur. These are all part of the accommodation reflex. So first of all, there is convergence of both eyes. Your eyes move medially to track the object. The second reflex action is accommodation. This is what I talked about before. The shape of the lens changes and the focal point is maintained on the retina. I talk about this in more detail in the lens video. And then the third part of the accommodation reflex is miosis. The pupil constricts to block entry of divergent light rays coming from a near object. So you can ask a patient to focus on a near object. You won't be able to see the change in the shape of the lens, but you should be able to see the eyes converge on the near object, and you should be able to see the pupils constrict. And if you see both of these actions, you say that there is a normal accommodation reflex. And this is a complex reflex circuit. It involves the visual cortex and much more involved circuitry than the light reflex circuit. One clinical correlation of the accommodation reflex that you should know for your boards is the Argyll-Robertson pupil, which is also known as a prostitute's pupil, because this finding in the pupils is strongly associated with neurosyphilis or tertiary syphilis. Patients who have Argyll-Robertson pupils have small bilateral pupils that do not constrict to light, but do constrict when the accommodation reflex is tested. This is known as light-near dissociation. This is believed to happen because tertiary syphilis can involve the pretectal nucleus, which is part of the light reflex but not part of the accommodation reflex. In any event, what you should know for your boards is that a patient who has small pupils that do not constrict to light but do constrict to accommodation, that patient likely has syphilis. And finally, on your clinical rotations, you will often see PERRLA documented in the clinical chart. This is the way we document a normal pupillary exam. It stands for pupils are equal, round, and reactive to light and accommodation, and it means you've examined the pupils, tested both of the reflexes, and found them to be normal. And that concludes our module on the